It's clear.
Okay. So, assalamu alaikum everyone. Good afternoon. I'm Ayat Hussein. I'm R2 cardiac surgery resident from King Faisal Specialist Hospital and Research Center. I'm going to talk about the guidelines about the diagnosis and treatment of aortic diseases from 2014 European Society Guidelines, European Society of Cardiology Guidelines. So as an introduction, in addition to coronary and peripheral artery diseases, aortic diseases contribute to a wide spectrum of arterial diseases. That's I'm going to talk about. So aortic aneurysm, acute aortic syndromes, like including the aortic dissection, intramural hematoma, penetrating atherosclerotic ulcer. And the other section is the traumatic aortic injury, pseudoaneurysm, aortic rupture, atherosclerosis diseases, and then the genetic diseases like Marfan and congenital like co-arc of aorta. So the overall global death rate from aortic aneurysms and aortic dissections increased from 2.49 per 100,000 to 2.78 per 100,000 between 1990 and 2010, with higher rates for men. On the other hand, the prevalence and incidence of abdominal aortic aneurysms have declined over the last 2 decades, and the burden increases with age, and men are often affected than women. I'm going to talk a bit about the normal and the aging aorta. So the aorta is the ultimate conduit carrying in an average lifetime almost 200 million liters of blood to the body. In healthy adults, the aortic diameter does not exceed 40 millimeter. This diameter is affected by several factors. So we have the age, the gender, body size, including height, weight, body surface area, and also the blood pressure. So the expansion rate, it's about 0.9 millimeter in men and 0.7 millimeter in women for each decade of life. The dilatation over mid to late adulthood is thought to be a consequence of aging related to a higher collagen to elastin ratio that Abdurrahman mentioned earlier, along with increased stiffness and pulse pressure. So collagen to elastin ratio, if it is higher, like in coronaries, for example, and renal arteries, then it will cause the arterial burst pressure to increase, and this will affect the dilatation and rupture. For aortic stiffness, some words, one of the earliest detectable manifestations of adverse structural and functional changes within the vessel wall, and increasingly it's recognized as a surrogate endpoint for the cardiovascular diseases, and has independent predictive value for all cause and cardiovascular mortality, plus the fatal and non-fatal also coronary events. As you see here, that for aortic imaging, we will answer many questions that have been raised last week about the imaging and so on. So as you see here, that the CT and CT, it has the benefit and transesophageal echo, but the CT has the negative point of radiation, of course, and the MRI also the ease of use. Okay, but CT is reliable also with the MRI. So for the general recommendations, so it's recommended that diameters should be measured at pre-specified anatomical landmarks perpendicular to the longitudinal axis, which is class 1. In the case of repetitive imaging of the aorta over time to assess change of diameter, so it's recommended that the imaging modality will be used. It has the lowest iatrogenic risk on the patient. This is class 1 level of the C. So when you need to repeat the imaging of the aorta over the time to assess the change of diameter, also you have to use the modality that is, it has similar method of measurement. So last week we have asked about, I think, the modality. For example, if we want to assess the diameter, so we want to use the CT. But for the radiation, is it possible to use MRI and alternate between CT and MRI? And I think this is the answer of the question, because you have to use the same modality. So this is it's a class 1 level of evidence C. And also it's recommended that all relevant aortic diameters and abnormalities to be reported according to aortic segmentation that you specify in your image. Also renal function, pregnancy test, of course, and allergy to contrast, it has to be tested before. It's class 1. The risk of radiation also has to be assessed, especially in young patients. It's 2A. And also you have to index the aortic diameter to the body surface area, especially for outliers in body size. Previous one was for the imaging, and now it's for the TEVAR. So Muhammad, I think he gave a summation for information of TEVAR, but here is the recommendation. So for TEVAR, it's recommended that the indication for TEVAR or EVAR decided on individual basis according to anatomy, pathology, comorbidities, anticipated durability of any repair that we are going to do, and also to use a multidisciplinary approach, which we hear all the time. So it's a class 1 level of evidence C. And we have to have proximal and distal landing zones, good distal and proximal landing zones of at least 2 cm recommended for the safe deployment and the durable fixation of TEVAR. This is class 1 also. For the aortic aneurysms, it's recommended to select the stent graft with a diameter exceeding the diameter of the landing zone, but by at least 10 to 15% of the reference aorta. During stent graft placement, invasive blood pressure monitoring control, either by pharmacologically or by rapid pacing, it's recommended. I've read about rapid pacing during TEVAR. So rapid pacing, it helps in the deployment of the stent or graft we have during TEVAR. So it reduces the cardiac output with a high rate of more than I think 160. So this will help in the deployment of this graft or stent and the stabilization of this one. If any comment for that, guys? If you have any comment?
Doctor, as you mentioned, pacing, some centers, they are using the pacing as routine and standard of care. There is other maneuver to reduce the blood pressure, heart rate. Sometimes
pharmacology, yeah, by medications. I think the adenosine we can use also as alternative.
Exactly, and some people, like we are in our center, we just stop the breathing of the patient, and we try to lower the blood pressure as mapped down to 60. Other than this, there is different maneuver, different from center to center.
Okay, thank you. And regarding the protection of the spinal cord and high-risk patients, as Abdurrahman mentioned, that we have to use the protective methods, and one of them is the cerebrospinal fluid drainage. Preventive cerebrospinal fluid drainage should be considered in high-risk patients. It's a class 2A level of evidence C. For the techniques in general and for aortic diseases, so those 4 sentences that I'm going to mention, they are all class 1. So cerebrospinal fluid drainage recommended for thoracoabdominal aorta to reduce the risk of paraplegia, as we mentioned earlier. And then the aortic valve repair using the reimplantation technique, which is I think the valve sparing. I think it's the same one. Or remodeling with aortic annuloplasty. It's recommended in young patients with aortic root dilatation and the tricuspid aortic valve. For the repair of acute type A aortic dissection, open distal anastomosis technique and avoiding of aortic clamping like hemiarch or complete arch, it's recommended. And I think if anyone can explain this, because I didn't understand the open distal anastomosis with avoiding of the aortic clamping like hemiarch, complete arch.
Maybe Dr. Khalid Garni can explain this, because doing the arch and ascending part is done by our cardiac surgeon in the center.
Okay. Anybody has a comment, or shall I continue?
This open distal anastomotic technique, I remember reading about it in the book, if you don't mind me commenting about it.
Yeah.
I think when you do it with the circulatory arrest, and then you do the distal anastomosis without clamp, once you're done with the distal anastomosis, you clamp the graft, and then you resume your circulation. I think that's what it is.
Okay. Okay, anyway, so in patients with connective tissue disorders requiring aortic surgery, the replacement of aortic sinuses is indicated. This is
Sorry,
the last one. Yes?
Sorry, what was the question?
About the box 3, sentence 3, repair of acute type A aortic dissection.
Okay, and open distal anastomosis, avoiding aortic clamp, hemi-arch, complete arch is recommended. Yeah, so what's the question exactly?
I mean, what do they mean by this sentence? Open anastomotic technique, avoiding aortic clamping with hemi-arch or complete arch.
You just do distal hemi-arch, then you resume your circulation. This must be done under circulatory arrest. If you are doing hemi-arch, you cannot do it if you are on pump. You need to do it on complete circulatory arrest.
Okay.
This is your question?
Because of the circulatory arrest, that's it.
Yeah, if you are doing hemi-arch or you're doing arch, okay, you cannot do that unless you are in circulatory arrest. Besides, if you are in circulatory arrest, you can do antegrade cerebral perfusion either through you are clamping the neck vessels or the arch vessels. Let's be more specified. You are clamping or the arch vessels, and either through the axillary or direct ostial to the arch vessels to perfusion. If you want to do great cerebral perfusion.
Okay.
Haytham, I think they are referring here the main idea just to avoid the clamping, because the clamping may increase the propagation of the dissection. So you don't clamp the aorta at all.
Yes, you can do that as well. Then you resume after circulatory arrest. You go circulatory arrest,
Yes.
then you open your repair. This is my, this what I explain it.
Okay.
Or if my explanation is not clear, so exactly what Hussein mentioned.
Okay. Yeah.
Is
Sure.
it now more clear with Hussein comments?
Yes.
Okay. Thank you, Hussein. Thank you.
Okay. So the other recommendations for 2A recommendations, selective antegrade cerebral perfusion should be considered for aortic arch surgery to reduce the risk of stroke. Also, axillary artery should be considered for cannulation. Also, it's the as a first choice, okay, for the aortic arch and in aortic dissection. Also, as my colleagues mentioned, that left heart bypass also should be considered during repair of descending aorta or thoracoabdominal aorta to ensure the distal organ perfusion. Now we are going to talk about acute aortic syndromes. That includes many things. So here for imaging modalities, as you see here that CT and MRI take the benefit of the of all the diseases. So for ascending aortic dissection, aortic arch dissection, descending aortic dissection, about the size, the thrombus, the intramural hematoma, or the aortic ulcer, or also the to assess the aortic branches and if they are involved or not. CT and MRI, they take the benefit of this, also beside the transesophageal echo. For the workup of those syndromes, then as a class 1, you have to assess the patient and you have to have suspicion that the patient is having this syndrome or not. So a clinical or a pre-test probability we have to have before to assess the patient condition, symptoms, and the clinical features. For the labs, it's 2A to, if you have a clinical suspicion that the patient is having this syndrome, then you do a biomarkers. Should always be considered if you are suspecting that the patient is having acute aortic syndrome. The other one for the labs, it's 2A to do, if you have a low clinical probability for these syndromes, then a negative D dimer level should be considered to rule out the diagnosis. I think D dimer has lots of diseases, it will be positive. So I don't know whether it will guide us or it will, we will be also confused more. That's why I was asking myself why here they put the D dimer itself. If anybody has any comment.
Can I comment?
Yeah.
A D dimer has a good negative predictive value, so it helps you to rule out. But if it's positive, it doesn't help that much, I think.
Yes, yes, this is what I mean. Anyway, to rule out, it might be beneficial. The other one, that in case of intermediate clinical probability for those syndromes, then with a positive D dimer test, you do further imaging, of course. And it's not beneficial or harmful maybe if you have high probability, like risk score of 2 or 3 for aortic dissection. Testing of D dimer is not recommended if you have the high suspicion of the aortic dissection. So the risk score of aortic dissection, I've read that it contains multiple things like the your examination and also the history of the patient, and also if the patient is high risk or not. So multiple things, and you give each one a 1 point, and then you calculate. If it is like 2 or 3 here, it's written in the recommendation, then it's you have high suspicion. For the imaging, transthoracic echo, it's recommended as a class 1 as an initial imaging. But in unstable patient with the high suspicion of those syndromes, then the following modalities should again be recommended and should be used. For transesophageal echo, it's class 1. Also the CT, it's a class 1 level of evidence C. For stable patients, and you have high suspicion for those syndromes, then CT is a class 1, MRI class 1, transesophageal echo, it's a class 2A. For if the patient is initially has a negative imaging with persistent suspicion of those syndromes, then you repeat the CT or MRI, it's a class 1. For chest X-ray, it might be considered for low suspicion of those syndromes, it's a class 2B. And then in cases of uncomplicated type B aortic dissection, you treat medically. So you repeat the imaging like CT or MRI during the first days. It's recommended as a class 1. For the treatment of those syndromes, then in patients with acute with aortic dissection, medical therapy, including pain relief and blood pressure control, it's recommended as a class 1, as my colleagues mentioned. And then in patients with type A aortic dissection, urgent surgery is recommended as a class 1. For patients with acute type A aortic dissection and having organ malperfusion, then we do a hybrid approach. And we do, for example, a percutaneous aortic or a branch artery procedure, for example. We should consider this in addition to the surgery itself. It's class 2A. For uncomplicated type B, medical therapy should always be recommended as a class 1. Again, for the uncomplicated type B, TEVAR should be considered as a class 2A. For the complicated type B aortic dissection, TEVAR is recommended as a class 1, and complicated B aortic dissection, also surgery might be considered as a class 2B. Moving to intramural hematoma. So intramural hematoma, Muhammad has mentioned some of the information. So it's an entity or within the spectrum of acute aortic syndrome. It's a hematoma, develops in the media of the aortic wall in the absence of an intimal tear, and it's diagnosed by the presence of circular or crescent shape thickening of more than 5 millimeters of the aortic wall in the absence of detectable blood flow. It accounts for 10 to 25 of those syndromes, and for type A, which involves the ascending aorta, it's 30%. For type B, for the descending aorta, it involves like 60 to 70% of the syndromes. 30 to 40% of type A intramural hematoma progress to aortic dissection, with the greatest risk within the first 8 days after the onset of symptoms. And then the overall, the long-term prognosis of patients with this disease is more favorable than patients with aortic dissection, of course. So the recommendations for management, and we'll hear those sentences also with the aortic dissection also. So it's class 1, that in all patients with this disease, medical therapy, including pain relief and blood pressure control is recommended. For type A, urgent surgery is indicated as a class 1. For type B, medical therapy initially under careful surveillance is recommended. And then if we have uncomplicated type B, repetitive imaging like MRI or CT is indicated as class 1. For complicated type B, TEVAR should be considered as class 2A, and complicated type B surgery may be considered as class 2B. So I think also Muhammad has mentioned some of those. So these are the predictors of intramural hematoma complications. So we have a persistent and recurrent pain despite aggressive medical therapy. This is a predictor. Also difficult blood pressure control, ascending aortic involvement, maximum aortic diameter of more than 50 or equal 50 millimeter. Also progressive maximum aortic wall thickness of more than 11 millimeter, enlarging aortic diameter, recurrent pleural effusion, the penetrating ulcer or ulcer-like projection secondary to localized dissection in the involved segment. This is also a predictor. Also the organ ischemia like brain, myocardium, bowel, or kidneys. Moving to penetrating aortic ulcer. So it's defined as an ulceration of an aortic atherosclerotic plaque penetrating through the internal elastic lamina into the media. It's 2 to 7% of all acute aortic syndrome. The propagation of the ulcerative process may either lead to intramural hematoma, pseudoaneurysm, aortic rupture, or also acute aortic dissection. For the recommendations of management of this disease, then it's a class 1 in all patients with this disease to initiate the medical therapy, including pain relief and blood pressure control, as we mentioned with the intramural hematoma. It's a class 2A that surgery should be considered with type A. With type B, initial medical therapy under careful surveillance is recommended. It's a class 1. For the uncomplicated type B, repetitive MRI or CT is indicated as class 1. For the complicated type B, TEVAR should be considered, and also surgery should be considered. But the TEVAR is 2A, surgery in type B complicated 1 is 2B. Moving to aortic aneurysms. Guys, you can stop me anytime if you want to ask any question. Moving to aneurysms, these are the recommendations. So when aortic aneurysm is identified in any location, you assess the entire aorta and the aortic valve as a baseline, and then you follow up the patient. It's a class 1. And in cases of aneurysms of the abdominal aorta, a duplex ultrasound for screening of peripheral artery disease and peripheral aneurysms should be considered as class 2A. Patients with aortic aneurysms are at risk of cardiovascular diseases, so you have to initiate the general principles of cardiovascular prevention strategies. It's a class 2A. So for interventions of ascending aortic aneurysms, it's a class 1 that surgery is indicated in patients who have aortic root aneurysms and maximal aortic diameter of more than or equal 50 millimeters for Marfan people. And then surgery should be considered in patients who have aortic root aneurysms and maximal ascending aorta diameters of those. So of equal or more than 45 millimeters with for patients with Marfan with risk factors, or more than 50 for patients with bicuspid valve with risk factors, or more than 55 for other patients with no elastopathy like the previous one. So it's 2A, class 2A. If you have a lower threshold for intervention for those patients, it might be considered according to the body surface area in patients with small stature or rapid progression or aortic valve regurg or planned pregnancy, or the patient preference also we have to discuss. So it's lower threshold and it's for intervention and it's 2B. For aortic arch aneurysms intervention, surgery should be considered in patients who have isolated aortic arch aneurysm with maximal diameter of more than 55 millimeters. It's 2A. For aortic arch repair, may be considered in patients with aortic arch aneurysm who already have indication for surgery. And adjacent, for example, of adjacent aneurysm located in the ascending or descending aorta, it's a class 2B. For the descending aortic aneurysms intervention, then TEVAR should be considered rather than the surgery when anatomy is favorable. It's a class 2A. Also, TEVAR should be considered in patients who have descending aortic aneurysm with a maximal diameter of more than 55 millimeters. When TEVAR is not technically possible, then surgery should be considered in patients who have descending aortic aneurysm with maximal diameter of more than 60. This is a class 2A, equal or more than 60 millimeters. Also, when intervention is indicated, in cases of Marfan syndrome or other elastopathies, surgery should be indicated rather than TEVAR. It's a class 2A. And this, I think it answers your question, Faisal. For the recommendations of management of asymptomatic patients with enlarged aorta or abdominal aortic aneurysms, so they are asymptomatic. So the recommendations are in patients with abdominal aorta diameter of 25 to 29 millimeters. A new ultrasound imaging should be considered 4 years later. It's a class 2A. And then surveillance indicated and safe in patients with AAA with maximum diameter of less and slow growth, which is less than 10 millimeters per year. It's a class 1. For patients with small, which is 30 to 55 millimeter AAA, the following time interval for imaging should be considered. So every 3 years for AAA with the diameter of 30 to 39, and every 2 years with the diameter of 40 to 44, and every year for more than 45 millimeter of diameter. As Abdurrahman mentioned, that smoking cessation is recommended to slow growth of AAA, it's class 1, and to reduce aortic complications in patients with small AAA, the use of statins and ACE inhibitors may be considered also. It's a class 2B. AAA repair, it's indicated if the AAA diameter exceeds 55 millimeter and the aneurysm growth exceeds 10 millimeter per year, it's class 1. If a large aneurysm is anatomically suitable for TEVAR, either open or endovascular aortic repair is recommended in patients with acceptable surgical risk. So it's a class 1. If a large aneurysm is anatomically unsuitable for TEVAR, then we do open aortic repair. It's a class 1. And then in patients with asymptomatic AAA who are unfit for open repair, then TEVAR along with the best medical treatment may be considered. It's class 2B. Then the patients who have symptomatic abdominal aortic aneurysms, then these are the recommendations. So in patients with suspected rupture for AAA, immediate abdominal ultrasound or CT is recommended, class 1. In case of ruptured AAA, the emergency repair is indicated as a class 1. In case of symptomatic but non-ruptured AAA, urgent repair is indicated also as a class 1. In case of symptomatic AAA anatomically suitable for TEVAR, then either open or endovascular aortic repair is recommended as a class 1. For the screening, I think Abdurrahman has put this image before last week. So for screening for population with AAA with ultrasound. So here you can see that it's recommended in all men more than 65 years of age, it's class 1. Then it might be considered in women more than 65 years old with history of current or past smoking, class 2B. And then it's not recommended in female non-smokers without familial history, and it's a class 3, non-beneficial for them. For the targeted screening for AAA with ultrasound should be considered in first degree siblings of patients with AAA, of course, it's class 2B. As an opportunity for AAA, for the transthoracic echo, it should be considered in all men more than 65 years of age as a class 2A, and then may be considered in women more than 65 years of with a history of current or past smoking, like the ultrasound. It's a class 2B in women. Now, moving to genetic diseases affecting the aorta, I'm gonna talk about some, not all of them. So for testing people with genetic aortic diseases, it's a class 1 to investigate first degree relatives, siblings, and parents of a subject with or a patient with thoracic aneurysms and aortic dissection to identify familial form in which relatives all have a 50% chance of carrying this mutation. And also, once a familial form of this disease is highly suspected, it's recommended to refer the patient to a genetic specialist for the family to investigate them as a class 1. For the management of aortic root dilatation with bicuspid aortic valve, then all those things are class 1. So patients with known bicuspid aortic valve should undergo initial transthoracic echo to assess the diameter of aortic root and also the ascending aorta. Also, cardiac MRI or CT is indicated in patients with bicuspid aortic valve when the morphology of the aortic root and the ascending aorta cannot be accurately assessed by transthoracic echo. Serial measurements of the aortic root and ascending aorta also indicated for every patient with bicuspid aortic valve. The interval depends on the aortic size, increases in the size, and also the family history. In the case of diameter of the aortic root or ascending aorta more than 45 millimeter or an increase of more than 3 millimeter per year, then measured by echo, then annual measurement of aortic diameter is indicated. In case of aortic diameter more than 50 or increase of more than 3 millimeter per year, then of course measured by an echo, then confirmation of the measurement is indicated using other image modality like CT or MRI. So we have a patient with bicuspid aortic valve, then surgery if the ascending aorta is indicated in case of the aortic root or ascending aorta more than 55 millimeter, aortic root or ascending aorta diameter more than 50 in the presence of other risk factors, aortic root or ascending aortic diameter more than 45 millimeter when the surgical aortic valve replacement also is scheduled for the patient. Using beta blockers may be considered in patient with bicuspid aortic valve. Yes.
آيات معلش انت قلتي الدايمتر more than 50 قبل شوي قلنا كلاس 2A ولا لا؟
دقيقة. وين أية
النقطة الثانية اللي هي لا أيوة النقطة الثانية aortic root or aortic diameter more than 50
in the presence of other risk factors.
يا قبل شوي طيب كلاس 2A
وين هذا دقيقة؟
في البداية روح أول سلايد ارجع مرة
أول شيء؟
إيه أول شيء
هذا في البايكاسبيد اورتيك فالف.
ايوه بايكاسبيد.
ايوه هو في البايكاسبيد اورتيك فالف. ارجعي مره ثانيه، ارجعي في البدايه هنا شوفي لا شوفيها تحت.
طيب يقول لك more than 50.
ايوه كلاس 2A وهناك كلاس 1 فيه
اوكي
ونفس بعض ولا لا؟
Yeah, I think it's the same.
اوكي
bicuspid and other risk factors.
بالضبط bicuspid with other risk factor وهناك برضه bicuspid with other risk factor.
طيب دقيقة نرجع لها. Oh yeah, it's the same.
مفارقة صح؟
أيوة مع إني أخذتها من نفس ال PDF يعني it's not different resources. Okay, we're gonna check it, no problem. طيب beta blockers, thank you for the comment. Okay, طيب beta blockers may be considered in patients with bicuspid aortic valve and dilated aortic root more than 40, and it's a class 2B. And for the familial occurrence of this disease, then screening of the first degree, as we said, should be considered also. And in patients with any elastopathy or bicuspid aortic valve with dilated aortic root more than 40, isometric exercise with high static load like weightlifting and so on, it's not indicated, should be discouraged. It's class 3, harmful for the patient. For the co-arc, then it's a class 1 in all patients with non-invasive pressure difference more than 20 between upper and lower limbs, regardless of the symptoms, but with the upper limb hypertension of more than 140/90. Then the abnormal blood pressure response during exercise or significant left ventricular hypertrophy intervention is indicated as class 1. Independent of the pressure gradient, the hypertensive patients with more than 50% of aortic narrowing relative to the aortic diameter at the diaphragm on MRI or CT, for example, or invasive angiography, then it should be considered for intervention also as class 2A. Here I noticed that they repeated the same sentence also with the in different classes, 2A and 2B. That's why I didn't delete anything, because 2A and 2B, it's different. I don't know if you know anything about this guy. This sentence, it's the same as here. If you have any comment about this.
Doctora, 2A and 2B almost the same because the level of evidence at C, so all it's opinion.
So it doesn't make any difference يعني.
Actually it's same.
ايوه بس هي بتكون less beneficial for the patient يعني.
So if we have 10 consultants, 6 of them, they said it's 2A, and 4 of them, they say 2B. From that, they put this as a recommendation, 2A or 2B, it's only voting.
Oh, okay.
Maybe also the definition of hypertension.
Okay. Okay, sure.
What do you mean by definition of hypertension, Dr. Farid?
If it's severe, more than 140 over 90, or not, it's not mentioned like this.
They didn't mention يعني yes, they mentioned no multiple definitions يعني for patients to take them for surgery. It's not one thing.
Okay. Sometimes they have these tables followed up by explanations and a statement in the bottom with different references to. So did you read the statements? What was going on there?
I read some statements, but يعني I didn't get why they put 2A, 2B. I don't know whether maybe I can again get back to this PDF. Maybe they have written something. And I'm gonna write it in the group. We'll see. Okay. For the يعني we are left with the atherosclerotic aorta, and then the traumatic aortic injury, and then we have the chronic aortic diseases. So 3 topics from now. So atherosclerotic aorta, for the management of aortic plaque, it's a class 1 in the presence of aortic atherosclerosis. General preventive measures to control the risk factors are indicated. And in the case of aortic plaque detected during the diagnosis and diagnostic workup after stroke or peripheral embolism, we have to initiate anticoagulation or antiplatelets, and the choice depends on comorbidities and individualizing patient assessment. And it's a class 3 that prophylactic surgery to remove high-risk aortic plaque is not recommended as a prophylaxis. For the traumatic aortic injury, it's a class 1 in case of suspicion of traumatic aortic injury to do CT. And then as a 2A, if CT is not available, then transesophageal echo should be considered. And also in case of this disease, then with suitable anatomy requiring intervention, then we do TEVAR. It's a preferred over surgery. It's a class 2A. For chronic aortic diseases, for the follow-up for a chronic aortic dissection, then it's a class 1 to do contrast CT or MRI to confirm the diagnosis of chronic aortic dissection.
Excuse me.
Yeah.
Can you go back to that one with the 2A and 2B?
Which one you mean, Doctor? This one?
Yes, this one. What I understand that 2A is if the patient is hypertensive. But 2B, that's mean independent for the gradient and the hypertension.
They've written the same: pressure gradient, hypertension, and patient with more than 50 aortic narrowing. It's the same.
First one is written independent to pressure gradient. Hypertensive patient will be class 2A.
Okay.
But it's written independent to pressure gradient and hypertension.
Okay, okay. Okay, yeah, sure. Maybe now it's more, I think, logic.
Okay. Yes.
Yeah. Thank you, Doctor. For chronic aortic diseases, we started with the chronic aortic dissection. So initial close imaging surveillance of patients with a chronic aortic dissection is indicated to detect the signs of complications as soon as possible as class 1. Then in asymptomatic patients with a chronic dissection of the ascending aorta, so they are asymptomatic and elective surgery should be considered as a class 2B. For the patients with a chronic aortic dissection, tight blood pressure control for less than 130/80 is indicated for as a class 1. And also surgical repair or TEVAR is recommended for complicated type B for aortic diameter of more than 60 and 10 millimeter per year as a growth or malperfusion or recurrent pain. Then we have to interfere as a class 1. For the follow-up after endovascular treatment of aortic diseases, then it's a class 1 that after TEVAR or EVAR surveillance is recommended after 1 month, 6 months, 12 months, and then yearly. Shorter interval also can be considered in the event of abnormal findings or that requires closer surveillance, so we individualize the patients. Also, CT is recommended as the first choice imaging technique for the follow-up after TEVAR or EVAR. It's a class 1. And if neither endoleak nor AAA sac enlargement is documented during the first year after EVAR, then duplex ultrasound we have to do with or without contrast agents. So it should be considered for annual post-op surveillance with non-contrast CT imaging every 5 years. It's a class 2A. So duplex ultrasound and the CT. For patients with thoracoabdominal aneurysms less than 45 millimeter, annual imaging is recommended, while on patients with more than or equal 45 and less than 55, every 6 months we have to do the imaging, unless there is the stability of the region is confirmed by serial imaging. It's a class 1. For the follow-up after TEVAR in young patients, MRI should be preferred to CT over CT for the compatibility of the stent graft to reduce the radiation exposure. It's a class 2A. And the long-term surveillance of open abdominal aortic repair may be considered at 5 years intervals using the color duplex ultrasound or CT. It's a class 2B. Thank you. Any question, guys?
I have a question, if you don't mind.
Yeah.
Regarding the recommendation of the ascending aortic aneurysm.
Ascending aortic aneurysm. Abdominal aortic. This one, Faisal?
Yeah, this slide.
Mm-hmm.
For patients without any genetic diseases or risk factors, should we go with 5.5 centimeters as a limit for intervention or 5?
I think it should be less. With with patients with genetic diseases should be less. Other patients should be
without any risk factors or genetic disorders.
You mean the growth, huh?
Yes, 5.5. You are right. Class 1, 5.5.
Class 1 is 5. Because here it's class 2A is 5.5.
You mean the last one, huh? More than 55 millimeter.
Yes.
Okay, for other patients. I think it's depends. It depends on the patient itself. Individualizing patients and following them up and see the stability and their symptoms. Maybe it's because of this. It has differences in multiple resources. That's why. I don't know whether one of the seniors can explain this.
According to your patient, but the cutoff it's 5.5.
Yeah, this is what I mean. Yeah.
Okay, thank you.
With me is 5.5. I did summarize this one before in my note, but I'm confused with this 2A.
Yes, me too also, because we knew before that 5.5 and some numbers are known, but in this PDF I've seen different things.
So
I can send the PDF maybe on the group.
So in this case, if you want to take two scenarios, for example, patients you mean with let's say 5.3 or 53, Faisal?
Yes, Doctor.
Okay, so 53, and he comes to you, shows up totally asymptomatic, no elastopathy, no history of rupture aneurysms in the family, and basically out of the blue. And the patient does not have any risk factors, no hypertension, and no other pathology to explain this. There are two types of patients. One of them who is so much worried, and he's so eager, and he's so pushing for surgery. Yeah, you can take him for surgery, and you can consider him earlier for surgery. After all, the guidelines are only a guideline, so you should look at other things which are not mentioned here in the guideline. You have very good results with those in your center. So yes, you can consider them earlier. And the old-fashioned teaching is that an aneurysm is an aneurysm. Even the 4 centimeters is an aneurysm. And even the 4 has a rate of rupture. Yes, it's not 100% within the next 1 year, but it has something. Does anyone know from the seniors what's the rate of rupture of 4 centimeter aneurysm over the next, let's say, 5 years? Haytham?
If it is more than 4 to 4.5, I think,
let's say it's 4.2 centimeters, 42 millimeters. What's the, if you want to talk to your patient, advise him and counsel him, what's the rate of rupture of such an aneurysm over the next 5 years?
I think 20%, but I have here.
That's actually the number that has been quoted. Anything above 4, it has about 20% rate of rupture. And this can happen the next day, by the way. For some weird reason. The patient may be excited, or he may get involved in an argument or fight, or something like this. Somebody punch him on the chest, or he may take an antibiotic that for a totally different reason that will accelerate this and rupture within few days. So the concern here of this particular patient, let's say he comes and he's worried. He's a professor in the university. He trusts you, and he thinks that you have very good results with very good no morbidity, no mortality. Yes, it's beyond the guidelines to operate on this patient. Usually we would consider conservative management, but because of the circumstances, you can take him for surgery. On the other hand, you may have somebody else who fits the guideline, okay? So he is, let's say, 56. And we actually had one patient like this, one of our colleagues, without mentioning any more details, he had a 57 millimeter aneurysm on the ascending aorta. But he was so afraid of submitting himself to surgery. So what would you do with this patient? Hi, Faisal.
I would try to convince him with the evidence that
because you're going to read the guideline and say surgery should be considered. Yeah. He said يعني تعرف معليش يا دكتور اعطيني موعد بكره. طيب خليني اجيك بكره اعمل ايكو ثاني ولا كذا. طيب بعد بكره ايش رايك اعمل ايكو بعد بكره كمان واتاكد. ايش تسوي معاه؟
First, I would try to convince him
طيب قلنا لك يعني انت قعدت معاه ساعه زمان وحاولت واقول لك طيب اديني خليني افكر، خليني اروح اصلي استخاره اجيك بكره، ايش رايك؟ ايش تسوي؟
A patient autonomy. I cannot make him do surgery that he doesn't
لا ما تكلبشه، ما تضربه على راسه بالمطرقه وتدخله على عمليات.
لا.
طيب فمعناته يعني some patients may refuse surgery. It is clearly indicated. You may ask for a second opinion. You may do this and this. He's still refusing. Those patients, you still can follow him up. But instead of following him up, like let's say after 6 months to a CT, you can tell him, why didn't you come again after 2 months or 3 months and do an echo? And if there's any slight increase in the size, you tell him, listen, this is going to rupture at any time. It's a time bomb. Find a surgeon if you don't like me. Find someone else. يلا يعني أقصد إيش so the guidelines specifically says if it's less than 55 it's not يعني it's not surgery should not be, well I shouldn't say that, surgery may be considered, but if it's more than 55 it should be considered. And in those circumstances, you may have a patient who does not fit that criteria, or he may have a psychological issue with that. He may have a problem with it. So you have to accommodate and try to find a way in between.
And this is what is mentioned, Dr. Farid. It's written here, the patient preference. For lower threshold for intervention, it's class 2B for the patient preference also. It's one of them.
But here we have a very high threshold for this particular patient. المستشفى كويسة والنتائج حقتها كويسة والجراح بالمرة ممتاز وسمعته طيبة وكل الأشياء تشير إنها يعني we should have a very good threshold for surgery.
Yeah.
بس المريض قال لا، فهيس يعني clearly it's indicated to go for surgery. فممكن هنا تروح معاه حاجة تانية تقول له okay we're gonna observe you we're gonna do مش عارف ايه، تعال لنا بعد شهرين بعد كده، يعني ما تضيع الموضوع ولا تضيع المريض كمان. بعضهم يقول لك لا خلاص روح ما ابغى اشوفك. طبعا يعني ممكن بهذه الطريقة تضر بعض المرضى بدل ما تقعد زي فيصل يحاول انه يقنعه مرات ومرات وكذا.
Yes.
Thank you. شكرا يا دكتور.
Thank you. Thank you guys.
يعطيك العافية دكتورة آيات.
شكرا آيات.
تفضل يا الملك.
شكرا دكتور آيات وشكرا دكتور فهد على حضوره معنا.
شكرا دكتور عبد الملك، يعطيكم العافية.
خلاص خلصتوا؟
إيه خلصنا هذه 3 ليكشر.
طيب جزاك الله خير. أنا أبغى أتكلم مع الشباب حقون التخصصي بس ما يعني موجودين، كم واحد منهم موجود معاكم؟
أنا شايف هنا آيات موجودة، محمد موجود.
طيب يا شباب اللي موجودين يعني لو سمحتوا من التخصصي سووا الجروب حق الصباح دحين على الحساب حقكم ونجتمع. على فكرة يا هيثم كل يوم ما زلنا